So this is just the grading for pneumonitis that I wanted to review. And we're going to focus, because I'm talking about early recognition, we're going to kind of focus up here. Grade 1 pneumonitis is totally asymptomatic. So this is something that I think for the younger clinicians in the room that haven't been doing this for a while, you're probably not used to calling this. And I will tell you, throughout my career on clinical trials, if there was some inflammatory change on a CT and that patient was fine, we were not calling it pneumonitis. We just weren't. We were just like, It would say inflammatory changes clinically correlate. And I would say, hey, how are you feeling? They're like, great. I'm like, okay, clinically correlated, it's nothing. And that's what we did forever, with any of these things, in the past. And so you're going to see higher rates of pneumonitis moving forward, some of which because we're using drugs that cause pneumonitis, but some of which is because I think we're smarter now, we're recognizing it. We're probably overcalling some of the grade 1s. Anything on a CT scan, I think at my institution, we're sort of calling everything now until we rule it out. So we're going to have to get smarter and kind of weigh things over time as we're calling these more appropriately now. But grade 1 means that patient is A-OK fine and there's something on the CT, which can be tricky. Grade 2 is any symptom. So grade 2 is a big spectrum from I had a slight cough or I'm just a little bit stuffy to, I'm coming in with, a cough that I can't get rid of. Grade 3 is severe symptoms. That's pretty obvious. And grade 4 is life-threatening. These are our patients that are on CPAP and likely intubated at that point. But we're focused on grade 1, too. So suspected case, if you suspect anything, if you see something on the CT and you have to have your sort of spidey senses on with the radiology reports, because these reports are read all over the place and they use different words. Like I just said, inflammatory changes clinically correlate. Your antennas need to go up. Ground glass opacities, your antennas need to go up. Waxing and waning, ground glass opacities dating back 3 years that no one's mentioned on the last 3 CT scans, that could just be inter-observer variability. You need to stop and have somebody relook at everything and make sure that patient didn't have baseline ILD coming into whatever antibody drug conjugate you happen to have her on. So you just have to have kind of a higher level of suspicion for anything that is commented on the CT scan and have a buddy that you can ask a question of to make sure that you know what's going on with your patient's lungs, because the same person isn't going to read your scan every time and they can use different words and see different things. So it can get tricky. And it's just one of the places where we have to just hone in and pay a little more attention. But you got to hold the drug while you're working that up. And we've talked about that several times. Just hold it for a few weeks and work it up. And if it's nothing, restart. You're not going to lose ground. You will lose ground if you treat someone with emerging pneumonitis. With any sort of symptoms, you start steroids. Don't wait. Start steroids and get them referred to a pulmonologist with some expertise in ILD. And I think hopefully Dr. Gupta and Dr. Haifez can comment on this a little bit more. They'll help you determine the grade, the treatment duration, the taper, and the discontinuation based on the severity of what they're seeing. So they really help. The multidisciplinary aspect of managing patients with symptomatic pneumonitis is quite important. And I hope that our community doesn't feel alone in trying to figure this out. It really does take a village to manage these patients effectively and safely and potentially re-challenge. The management per grade for grade 1, as Dr. Grisham said, some drugs allow you to continue for grade 1 and some say hold. Most of the topoisomerase 1 payloads, TDXD, RDXD, you hold with any symptoms, even mild ones. Grade 1, mirvetuximab, tisotumab do allow continuation from the clinical trials. I'm just going to tell you, be cautious with that, because that was in an era in recurrent disease setting where they weren't going on to other things that also might cause pneumonitis. This is a different era that we're living in now. We may not want to push patients with diagnosed grade 1 ILD to continue treating with a drug that's going to continue to cause lung damage when we want to use these other drugs. So I think we're going to have to be flexible in our management around grade 1. And personally, I would tell you to have caution when doing that and make it really an individualized therapy. Grade 2, we have to hold, start steroids, get them to pulmonology, as I mentioned. And grade 3, they're almost always in the hospital. at this point, being managed by a multidisciplinary team. So again, grade 1, you can monitor. We have all of our patients seen by pulmonology with grade 1. And we have a little bit of a debate, and I'd be interested to hear what Dr. Gupta and Haifez say about starting steroids for grade 1. We like to start them because we get rid of it faster and then we can restart. But sometimes it just goes away in a few weeks and you don't expose a patient to high-dose steroids, which is also beneficial. And so there's some, I think, clinical equipoise here around whether or not you should use steroids in grade 1, so we'll come back to that point as a discussion point. Grade 2, we're always starting steroids. High dose versus moderate dose depends on the clinical situation, how symptomatic is that patient, and then close monitoring and permanent discontinuation, unless there is a clinical trial where there's a re-challenge question. Outside of clinical trial, it would be against the guidelines to re-challenge. This is not super common, but also not rare, and this is just deruxtecan data. I think we're seeing it across all of the ADCs, though, so I don't think you should ever be lulled into a false sense of security that you're using an ADC that we're not talking about pneumonitis in. We talk about it a lot with TDXD. It's not just a TDXD thing. We're seeing it across the board at different levels, so you really have to be looking for it with any of these ADCs while we get more data, especially as these move into the wild in clinical practice. We really will see what the true rates are and risks to our patients. So I think we have to really remain vigilant with all of these drugs. These are the 5 S's, and these will be in your slides. I think, again, for the learners in the room, this is just really what we want you to pay attention to. We always want to do baseline screens. I'm going to talk about that in a second. Look at your risk factors, assess baseline lung status and other risk factors for risk of significant ILD. Scanning, high-res scans, we've talked about that. If you're on an ADC, even if all the disease is in the abdomen and pelvis, you have to get a chest CT, which some people don't do. Now you have to get a chest CT to monitor, and sometimes insurance pushes back on that, which is really annoying. It's a must do. We have to monitor the lungs when patients are on ADCs. Multidisciplinary teams, that's the synergy, are really important, and they look very different based on your practice location. Holding therapy is a key component. Suspension of treatment is a key component. We've talked about that, as are steroids. Don't be afraid to hold and initiate steroids while you're working something up. This is tricky, though. This baseline recognition of someone who's at risk, you're like, okay, I'm going to start really looking and making sure I know my patient's baseline status so I can use this drug safely. And I'm going to look at the CT for any abnormalities. Do that, yes. But it's tricky, and this is really nice data out of Dana-Farber, where they went back and they looked at patients who were on TDXD. And they went back to the baseline CTs that very smart medical oncologists looked at and said that patient was okay to start TDXD, and they had them all centrally re-reviewed by a radiologist to say, what would you have said if you had been given the opportunity to look at this? And 92% of the patients who started TDXD with recurrent breast cancer had some baseline radiographic abnormality. Almost 100%. So if you use that to gate access to any of these ADCs, we're going to be not using them, in anyone. But then do all of these patients need a baseline PFT? Probably not. Do they all need a baseline high-res CT? Probably. Do they need a baseline pulm consult? Let's get some input from our pulmonologists. How much do I have to do before I feel comfortable I can start one of these ADCs? And how much is overkill and delay and cost added to a patient that they didn't need? This is tricky. This is just what they found when they looked at the types of abnormalities. And ground glass opacities, that's GOO that is there on both sides. They looked at association with the patients who went on to be diagnosed with pneumonitis. And they couldn't find a baseline abnormality that was the aha. Well, of course, I wouldn't use it in this group, but I could use it in this group. It was all over the place. So this is tricky, and again, I think just emphasizes the point that we're not trained pulmonologists as much as we like to think we can do everything. And so getting advice on what actually is there and how severe it is before we start this medication can be very helpful in helping our patients get the benefit without the risk to these medications. When they went back and looked, rescored things, the interesting thing was they found a lot more grade 1 pneumonitis when it was rescored, but the grade 2 is exactly the same. So physicians are very good at detecting even mildly symptomatic ILD. We're good at diagnosing that. We're not good at diagnosing grade 1. And then the question is, well, if I'm only missing things that didn't progress to grade 2, am I still doing a good job? And this is really what we don't quite know yet. Are we holding too much? Are we not holding enough? We're still learning that in our population. And so I think we need to be flexible and continue to learn over time. And what we do now may pivot, in a couple years. But really, it's the collaboration that's key. Stop, hold the drug, and then collaborate with your pulmonologist and radiologist to really make the best decision for your patient. So in multidisciplinary management is key once you suspect anything with ILD and holding the drug. The other thing I'll say is direct communication with pulmonology is also really key. If you refer someone to Pulm in your community with asymptomatic ground glass opacities, they'll see them in 3 months because it's just not urgent. They don't understand the urgency necessarily unless you have, a group like Dr. Gupta or Dr. Haifis who are used to dealing with us. So you have to call and say, hey, I'm holding drug until you tell me I can retreat or you think this is serious, so that they understand the actual question that you're asking. So I think a direct reach out is really important. So for grade 1 asymptomatic, grade 2 is symptomatic, grade 3 is severe. The workup we've talked about, it's high-res CTs, pulmonology consults, PFTs, and sometimes bronchs. We also check blood cultures as well to look for infectious causes. We are interrupting, permanently discontinuing for grade 2, and the management really does depend on the severity of what we find, symptoms, and the dose of steroids is something that I work with our pulmonologist to determine. So grade 1 and 2, this is what I've been talking about. The controversial topics is we find a lot of grade 1 ILD, I treat it and it goes away, can I retreat? And the answer with consultation is yes, we can retreat. We have this data from breast cancer. We have to be very careful, but emerging data is telling us that patients that are successfully treated and rechallenged are rechallenged often very safely. About a third of them can recur with usually grade 1, and then they do have to permanently discontinue. But with close monitoring, at least the data to date, we don't see patients recurring with significant i.e. fatal or needing hospitalization ILD. So grade 1, there's emerging data that will show us it's safe. For grade 2, there are case reports, but there's not clinical trials yet, and so I would caution you strongly against doing this outside of clinical trials with very close monitoring and follow-up, because this could be quite dangerous to patients, and it's very frustrating to not be able to rechallenge. But I do think, if you have a death, you will learn that this is not a good idea. So grade 2, you really have to hold the line and not rechallenge. So this is a nope.